Hello, my name is Bianca Villalobos, and today my webinar will be about telehealth considerations for providers working with culturally diverse patients. I have no financial, personal, or professional conflicts of interest in this training. And I'd like to now present you with the learning objectives. First, we'll describe the effectiveness of telehealth and how it can be used to increase access to behavioral health services for both rural and underserved populations. Second, by the time we finish this webinar, you'll be able to provide some examples of cultural and linguistic considerations that can impact service delivery via telehealth. Lastly, we'll identify best practices, strategies, and tools for adapting behavioral health services to telehealth. Before we continue with this webinar, take a moment to consider the following two questions. Think about how you might respond, and at the end of the webinar, I'll ask you to revisit them. The first of these pre-test questions is that research on the effectiveness of telehealth for behavioral health problems has shown A, telehealth is less effective than in-person treatment, B, it's equally effective compared to in-person treatment, and C, it's more effective than in-person treatment. Question 2 asks whether telehealth services may be appropriate for certain populations. The first option is that patients with high suicidal risk and who don't have access to technology for visits or check-ins may not be appropriate for telehealth. Or B, patients who need a family member to help them with technology. Or C, patients who need an interpreter may not be appropriate for telehealth services. So take a moment, you can pause the recording and reflect on these questions and how you would respond to them. Although telehealth has been used since the 1950s to provide clinical services, it wasn't until COVID-19 and the pandemic that telehealth services have become a necessity to providing services during social distancing and isolation safety measures. Telehealth has become an important vehicle for providing both healthcare and mental health services. My plan during this webinar is to cover the following topics. We'll discuss the telehealth model of care, evidence for its effectiveness, linguistic and cultural considerations, best practices for using telehealth with patient encounters, and a case vignette to help us practice thinking about who might be appropriate for telehealth and some of these linguistic and cultural considerations that I'll be reviewing. In order to understand the expansion of telehealth and the need for culturally sensitive mental health services, I think it's important for us to place this need within the context of current events. Now, Latinos in Rhode Island comprise about 16.3% of the population in the state. However, they also represent 29% of COVID-19 cases and 26% of those hospitalized due to COVID-19. So we see that they overrepresent COVID cases and hospitalizations compared to their general representation in Rhode Island. Wang and colleagues published an article in January 2021 on data from 10 Providence Community Health Center clinics. They collected this data from approximately 60,000 patients, or 1/3 of the total population in Providence. Let's take a look at the figure on the left, which shows new positive COVID-19 cases and estimated incidence by race, ethnicity group, and by week. The red line represents the weekly COVID-19 incidence of the Hispanic or Latino population over the reopening phases compared to other populations. So the green line represents non-Hispanic Black populations, and the blue line represents non-Hispanic white populations. The dotted black line represents, in general, the population of Rhode Island. So what we see is that the weekly incidence rates among the Hispanic Latino population have been significantly higher than the statewide weekly incidence rates since the pandemic and throughout the reopening phases. The researchers of this study explain that the disproportionate rates of illness among Latinos and Blacks are likely due to pre-existing disparities. These include 1, lack of access to healthcare, but lack of access to testing and medical insurance. In addition, Latinos tend to have less opportunity for social distancing due to their essential worker status and the fact that they may live in multi-generational households. In addition, financial or employment concerns may prevent many from isolating at home because of the need to work and support their families. Clearly, there is a high need for quality mental health services during the social distancing and shelter-in-place orders to prevent spread of the virus while meeting the needs of patients and communities. Even after the rollouts of the COVID-19 vaccine, we see that this is still a population that continues to have a disproportionate impact in terms of access to the vaccine. So let's talk about the different terms used to describe remote services. The prefix tele means from afar or at a distance, and telehealth is defined by the Health Resources and Services Administration, or HRSA, as the use of electronic information and telecommunication technologies to support long-distance clinical healthcare, patient and professional health-related information or education, and public health and health administration. So telehealth is used to encompass a broader definition of remote healthcare. It's this umbrella term. In Spanish, you would call this telesalud. And it goes beyond the doctor-patient relationship and doesn't always kind of comprise of clinical services. So telemedicine is defined as using these telecommunication technologies to support the delivery of medical, diagnostic, and treatment-related services, usually provided by doctors. And this can include, monitoring a patient's progress after treatment or therapy, facilitating them having access to a specialist if the specialist is not in the same place as the patient, and conducting diagnostic tests. So with telemedicine, within that, we have our specialty areas, and these include telemental health, telebehavioral health, telepsychiatry, and telepsychology. All of these describing remote services for behavioral and mental health problems. So what does telehealth mean for us in terms of clinical encounters with patients? What we usually mean by telehealth is this two-way, real-time interaction and communication between the patient and the service provider, who's usually at a distant site. We're also talking about the use of interactive equipment, and that includes, in a minimum, audio and video equipment. We can also think of telehealth as a standalone service or a service that is used in addition to in-person services or to augment in-person services. In Module 1, I described the many attitudinal and structural barriers that make it difficult for Latinos to access mental health services in general. Telemental health can increase access to quality evidence-based treatments for underserved Latinos and can keep them in treatment for a variety of reasons. One of them being that telehealth is cost-effective for mental health care. It means that we can reduce travel time for patients, reduce transportation costs, and miss work, all from the patient perspective. In addition, as providers, we can increase the geographic coverage of our treatments and the dissemination of evidence-based interventions. So we can reach more patients than we would normally be able to reach if we were seeing them in person. And that means we can increase access to evidence-based treatments. In addition, telehealth can reduce stigma because patients can be seen from a variety of remote locations, and they don't necessarily have to travel to a specific mental health clinic for services. So behavioral health services alone, because they take place in primary care, help address stigma, and telehealth can further reduce some of those attitudinal barriers because patients can be seen from home, children can be seen at school, people can be seen at their work site during their lunch break. So there's very little kind of awareness from an outsider's perspective that your patient is seeing a mental health provider during those visits. In terms of the evidence supporting telemental health, the bottom line is that it is an effective therapeutic modality. We see that it is as effective as in-person treatments, And this is true for both children and adult populations and across a variety of disorders, including anxiety, depression, PTSD, and insomnia. There are a number of additional randomized control trials that I haven't listed here, and also studies that are not randomized control trials that still show that telehealth is an effective and feasible way to provide services to populations that are underserved and ethnic minority groups. We know that it's as effective in the United States and globally, and it leads to high satisfaction among patients. We also know that the standard of care is the same as in-person treatment. So although telehealth increases access to services for many underserved groups, it has its own challenges. So I want you to take a moment and think about your clinical role. What has been the most difficult challenge of doing telehealth? I've heard many providers and team members say that they have difficulties connecting to patients in terms of using the technology and actually initiating the calls or having them accepted from the patient's end, that patients lack access to technology, that more training is needed on how providers can use telehealth. And some people worry about maintaining confidentiality over video conferencing platforms. Others worry about working with high-risk populations remotely. Others discuss the challenges of time and scheduling these telehealth sessions with patients' busy schedules. So those are just some of the things that I've heard from providers and team members, but I want you to consider the most difficult challenge that you have faced in your clinical role. When attempting to meet the needs of diverse patients via telehealth, we need to account for logistical issues and those issues related to the actual use of the technology and the patient's language and their culture. According to the Pew Research Center, Hispanic and Black individuals are less likely to have desktop and laptop computers at home and less likely to have internet access. And although smartphones can help bridge internet access gaps, other data shows that Blacks, Hispanics, and lower income smartphone users are about twice as likely as whites to have canceled or cut off their service because of the expense. I know from working with many individuals that the end of the month can be particularly difficult for individuals to maintain their cell phone service until the end of the month when bills are due. So many times people end up, not having service on their smartphones that last week and are unable to schedule via telehealth till the next month or the next week after they've paid their bills. So consider when you are scheduling appointments for telehealth with patients who have difficulties, having regular access to a working cell phone. And consider changing when you schedule some of those things so that those visits are not occurring maybe at the end of the month when they do tend to cut off their service. Also consider that the Latino population is a younger population, and so they might have more experience with technology from school, especially now during the COVID-19 pandemic. Many young individuals have had to do remote learning. And so they may be familiar with video conferencing on their computers. However, service providers like us may struggle to connect and maintain contact with clients because of their lack of access or mistrust of technology. So it's very important to assess technology and digital literacy among our patients, thereby, taking a look at their level of acculturation and familiarity with use of technology, their comfort with the technology, their access to it, and what devices they typically use. Are they more familiar with their smartphone than the use of a desktop or laptop computer? As we consider these different kinds of devices, we might need to change our approach to sharing materials via video conferencing platforms because we need to now consider the screen size of those devices. For example, as you can see in this image on this slide, the screen size of a desktop or laptop computer is going to be very different from that of a smartphone. So if you tend to use screen sharing functions on these video conferencing platforms, consider what those screens will look like, those materials that you share via screen sharing, what they might look like to the patient on the other end, and that it can be quite difficult to read text or handouts with a lot of text on them when you're looking at them via a smartphone. We also, given people's comfort or familiarity with technology, we must teach some patients how to use the device or how to use the platform that our clinic is using to connect with patients. So although they might know how to use FaceTime, or they might know how to use social media, video apps, they may not be familiar with the clinic's platform for telehealth or behavioral health visits. As we're talking about these different kind of varying levels of digital literacy, we should also consider the need for some patients to be seen in person for an initial visit with telehealth, so that they can learn how to use the technology with the provider before they fully transition to telehealth only services. So an in-person meeting might be a great opportunity to do some of that coaching for the patient before they, or practice with the patient before they go home, and then must do this on their own to connect for future visits. Many providers have also mentioned that their patients prefer to use audio-only telehealth and are hesitant to use video. Exploring these reasons for being hesitant, or reasons for preferring to use audio over video on their platforms, this exploration of these reasons can help shed light on specific barriers like access to a web camera or concerns about privacy. And so once you can identify what is leading to that kind of hesitation to use video, you can engage in some problem solving related to access issues or concerns, like I said, about privacy and confidentiality during telehealth visits. But a recent study published in February 2021 by McClellan and colleagues has indicated that video conferencing can be more effective than telephone-based mental health services. In this study, they found it to be true of treatment for depression and trauma with veterans. There are many reasons why having eyes on your patient may benefit the treatment process, but now we have some evidence to consider how this might have a direct impact on patient improvement of symptoms. So, although this study only took a look at depression and trauma treatment with veterans, we have some initial evidence to say that video can be better over just audio services alone. So, as I mentioned earlier, when I started discussing this, some patients are hesitant about using video conferencing for telehealth visits. So you might discuss some of these results from the study when you are addressing some of the concerns that the patient has about using video. You know what? We have some initial evidence to say that you might actually get better faster with video-based services rather than just us talking on the telephone. So consider, their access to a web camera and video conferencing for those who do have the option of doing video, and thinking about how we might encourage or motivate clients or patients to use that video for their telehealth sessions. In the US, Asian and Hispanic populations are more likely than whites to live in multi-generational family households. In addition, immigrant populations are also more likely than those born in the US to live with multiple generations of family. This may pose specific challenges for patients who are engaged in telehealth, but because they are having a difficulty finding a quiet place in the home for visits, or finding a private place for visits. I've actually had some patients prefer to be seen in their car because there was too much noise in the home, or they've gone outside and worn headphones to help us have a better visit and reduce some of the interference caused by other people in the home, engaging in other activities, or busy, working from home or doing school at home. So when all those other activities are going on, we need to kind of engage in some problem solving with our patients in order to help them find a quiet or private place to have services. The cultural value of familismo for Latinos may be particularly salient as you interact with patients who used to be primarily connected to resources through schools and churches, and that now during the pandemic, these connections have been disrupted. Also consider family responsibilities may make it difficult to engage in telehealth. For example, I was providing supervision to a psychology doctoral student who was seeing a patient that had recently been diagnosed with COVID-19. She had tested positive and was told to quarantine at home in a room where she could isolate herself and not have contact with others at home. However, this was almost nearly impossible to do because this patient was the main provider of transportation for the rest of the members of the household who had to continue working. So there was no real way for her to quarantine at home because she was the one who had to drive people to work in order to help them financially support the family. And her quarantining or staying isolated in a room was also very difficult because it was a multi-generational family household with grandparents and children sharing rooms and areas of the house. So consider how some of those family responsibilities might impact your patient's ability to engage in telehealth services, but also their ability to engage in treatment recommendations. So going back to that same example, when my student who was providing services would call this client to engage in telehealth, the client was usually answering the phone while she was driving in the car and had to cancel or reschedule the visit. So that's just another way that those family responsibilities or other duties that they have might get in the way of scheduling telehealth visits too. Family support can be a tremendous protective factor for patients and for those that value family involvement in their treatment. Family members can help with medication adherence. They can help remind patients about homework or activities they need to engage in for their behavioral health visits, or in practicing skills, even helping those unfamiliar with technology connect with providers. So if you have a multi-generational family household and you have young ones in the house who are much more familiar with technology or who are already engaging in distance learning, they can help our older patients or those less familiar with technology initiate telehealth visits. Even if, like I said, it's just to answer the call or disconnect at the end of a visit. This can really reduce the burden that some individuals may feel about engaging with the technology and can make them more likely to use telehealth for future services if the burden and the amount of work involved with getting connected to providers is lessened with the help of others. Other cultural values like personalismo, simpatía, and confianza are all related to the development of rapport and the therapeutic alliance between members of the healthcare team and the patient. It's important that these interpersonal preferences be considered in your ability to have a good working relationship with the patient that you may have never met in person. So usually we might, engage in some chit chat, getting to know the person in terms of our assessment of some of the problems. We might get a lot of great valuable information from seeing the patient in a traditional in-person behavioral health visit. However, when we start seeing these patients online first or initially and never have a chance to see them in person, we might have to engage in some more focused strategies on developing that rapport and that alliance with those patients who you have never seen in person. So in terms of the Latino population, this population tends to be a higher context communicators than individuals from other cultures in the United States. So nonverbal elements like voice, tone, gestures, facial expressions, and eye movement are all significant variables in terms of telehealth communication style. So with Latino populations, verbal messages can sometimes be indirect. So although you may see me looking maybe anxious or sad, and you can tell from my affect, from my facial expression that I might be feeling that way, I might give you a message that conflicts with that. And I might directly tell you that I'm doing fine, but that might be in conflict with what you're seeing or what you're noticing via telehealth. So it's always great to clarify, although, they're saying they're okay, you see them kind of looking kind of down or depressed. And what is that about? With Latinos, we might also consider how time is seen more like a process, and perceptions of specific appointment times that with start and end times, they might be different. Those perceptions of time might be different. So you might have patients connecting, later or joining their session late, a few minutes late, or not getting the cues of finishing up a session until they've finished talking to you about their difficulties, or making sure they get to all the things that they want to ask you about. So having a 20-minute session might be difficult with some of these patients, especially if they have other family responsibilities. So they'll get to your visit once they get to your visit and they finish doing whatever else they need to do before your visit. Learning often occurs by observing others. As you think about modeling or demonstrating techniques to your patients, think about how you can incorporate these things. For example, relaxation techniques or other strategies to manage or alleviate symptoms, and how you might show these techniques via telehealth. Consider again, you have a limited amount of screen space to do demonstrations and have to rely mostly on what's going on from your shoulders up. And so demonstrations that involve the whole body might need to be conducted via video, a video link that you send to your patient on how to do, for example, progressive muscle relaxation with all parts of their body. So the way that you demonstrate techniques to your clients may be different via telehealth. Think also about the communication style of your patient in general and how it might change via telehealth. How their openness to discuss symptoms may be different. They might have been very open with you about symptoms in person and kind of are more hesitant to talk about those things, or more reserved when they discuss problematic behaviors or things that are bothersome to them. It could also be the other way around, where they might have been very, reserved in person, but once you started doing telehealth with them, they might open up a little bit more. Some people feel like that actual physical distance can be helpful to expressing some of their difficulties. So think about how your patients might all have different communication styles. And for some, the way they communicate in person might be different when they transfer over to telehealth, and then vice versa. You think about, emotional suppression. When we're talking about, that expression of emotions might be different because of the modality. Limited English proficiency patients and monolingual Spanish speakers can have difficulties connecting to their providers for telehealth appointments because of language barriers. The language accessibility of online platforms and of messaging systems are not usually tailored or easily changed to be accessible for non-English speakers. So think about, these patients who are non-English speakers are less likely to use patient portals online to communicate with their providers. Think about how the links that are sent to patients to connect to telehealth visits are usually in English and not in their preferred language. So if a a patient of yours was to receive, for example, this Blue Stream platform text message to connect to their telehealth appointment, they are not going to kind of be able to acknowledge that this is the cue to log into their visit unless you do some prior coaching to help them recognize these messages as messages for you to connect to your provider. Think about telehealth platform language accessibility. So, for example, I mentioned Blue Stream. The Blue Stream platform itself may not be in the language of the preferred language of the patient. And this can be true of other platforms as well, including Zoom and video. There are numerous platforms available to do video conferencing with patients, but they might not be easily changed to the preferred language of the patient, so they know which buttons to press to open the chat box, to start or end the call. So coaching, again, is going to be really important for helping non-English speakers use the technology that the clinic is using to connect to visits. And as I mentioned previously, a family member can help be a supportive person at home when you're trying to connect with patients. Regarding the use of interpreters via telehealth, there are a few ways to get them connected to patients, but some problem solving may need to occur to overcome potential challenges. So some ways that interpreters can connect are telephonically. So if you call up the interpreter while you are video conferencing with your patient, the interpreter can listen in on the conversation and provide interpretation to the patient and the provider. You have on-site interpreters and also video remote interpretation, where you can connect the interpreter to the call that you are already holding with the patient. In theory, it should be easier to loop in an interpreter into a telehealth visit. For example, for a virtual visit, doctors don't have to go through the logical steps of getting the extra person in the room if they have interpreters on staff, or the need to have to fumble around with an iPad or a phone while they're examining a patient if they rely on remote services. But in reality, there aren't really great seamless ways to add a third person to video calls. So you should consider, the amount of time it might take to first connect to the interpreter via video conferencing, and then allowing enough time to connect with the patient so that there is this three-way virtual interpretation going on. Consider the quality of the audio that the patient has and your own quality of audio, because that can impact the interpreter's ability to relay messages, to hear the message and then be able to relay it. You might have noticed, over your own experiences via telehealth, that it can be difficult to identify when it's your turn to speak in a conversation. And a lot of times we have people speaking over one another. And when we have an interpreter involved, we've got three people involved in that interaction a lot of times, and it can be quite difficult to manage, when someone's done speaking and the interpretation can start. So think about holding pre-sessions with interpreters where you can go over some cues or the way that you're going to carry out the visit so that you can facilitate that process of interpretation. And as I mentioned before, more time might be needed for interpretation to occur via telehealth. In general, I have some recommendations before beginning to use telehealth with patients. In some cases, you might not have that option. You might have to use telehealth in that initial first visit. But I believe that you can still conduct some assessment of the person's familiarity with technology while you're doing your cultural assessment. So if you do have the option of holding in-person sessions, I would recommend doing that for an initial first visit with the patient in order to check their smartphone and internet access, ask about their experience and perspectives on technology, so that you get a better sense of how appropriate telehealth might be for that individual, or of the potential barriers you might encounter later when you do transition to telehealth. Be aware of your own experiences and perspectives on technology and how these beliefs or experiences might impact your interactions with patients. So your own view of using technology or about telehealth might make you more or less inclined to use the technology and the tools that are provided on the platform for the video conferencing system that your clinic is using. So think about your own familiarity and experiences with the technology. You might also need to focus on the current social environment of the patient. So who the patient lives with, their work demands, and their family responsibilities, because as we mentioned before, all of these may impact your ability to successfully connect with the patient at home or to find a private and quiet place for them to conduct the session and to schedule telehealth appointments with the patient. So, despite the strong evidence that mental health interventions like cognitive behavioral therapy are highly efficacious in treating a variety of mental and behavioral health concerns, they frequently rely on written materials and between session assignments, and these can sometimes serve as impediments for clients with limited English proficiency. But in general, I want us to think about how a lot of the tools that we might use in behavioral health visits rely on completing some kind of handout and worksheet. For example, screening measures done at the beginning of appointments require the use of filling out a questionnaire or using a scale to respond. Self-monitoring forms and worksheets, we usually provide these to patients so that in between sessions, they can track either their medication adherence or their behavioral activation. We provide psychoeducational handouts. And when we engage in safety planning, we usually write out these safety plans. So how can we still engage in all of these activities or use all these tools while we are using telehealth? And so we can use the different functions of the telehealth platform to our advantage. So for example, some video conferencing platforms have what is called a whiteboard function, where you can share a screen with the patient, a blank screen where you can write, where you can type, where you can draw and demonstrate concepts to patients. And as I mentioned, the screen sharing function can be particularly useful, especially when conducting assessments or screeners with patients who are limited English proficiency and who might rely on a visual analog scale. This can help facilitate the screening process because the options or the responses are visually available to the patient as they're answering your questions. So for example, the University of Washington Ames Center has this visual analog scale to the right for the GAD-7 and the PHQ-9. So it's also available in Spanish. The chat function can be used to send links to patients, links to videos or specific web pages that you want them to be familiar with, or files, for example, a specific monitoring worksheet or a calendar for them to do some tracking. So some platforms have this chat function where you can copy and paste a link right into the chat box for the patient to access from their end. In this example on this slide, I'm showing a patient a video, a psychoeducational video about depression. And I can provide for example, the YouTube link in the chat box and also send them a PDF file of a monitoring handout for monitoring their behavioral activation or the activities that they're engaging in for depression. In terms of some of the handouts and the worksheets that we typically use for behavioral health sessions, some of these can be converted to fillable PDFs. You can also use a Word document, a very simple Word document where a provider can act as the scribe while the patient provides their responses to questions or to for example, this behavioral activation sheet where you have to list activities that you enjoy doing, responsibilities that you need to take care of, and rate your depression, pleasure, and level of achievement from engaging in each of these activities. So while the patient is speaking, the provider can act as a scribe and complete these forms for them. Consider using PowerPoint presentations. I tend to use them a lot for psychoeducation and also for demonstrating techniques, because I can just put images on the PowerPoint slides to convey the message that I'm trying to convey. Especially with limited English proficiency clients, visuals can be much more useful for conveying important messages about symptoms than to provide a list of the symptoms that they might experience, of a written out list, compared to these visuals and images that they might relate to or identify with. There are also several advantages of using telehealth for behavioral health problems, and some of those advantages are that we can use video conferencing to get insight into the home environment and the living conditions of our patients. So we can see, that they don't have a private or quiet place at home, and they can give us a tour if we ask them. They can show us around what the home looks like or where they plan to hold their telehealth sessions, and we can help them problem solve ways to engage in the visit when there isn't a space or a private place for them. The patient can also bring you with them for in vivo exposures. So you can, in real time, help them or assist them during that exposure activity. For example, if they have to go to an elevator or they have to ride a train, whatever those feared situations are, they can now bring you with them if they have, that Wi-Fi or internet access on their smartphones. We can also teach parenting skills live when and while the disruptive behavior occurs with children. So you can, in real time see the disruptive behavior that you might have not normally been able to witness in a behavioral health visit, because the child is either, in school, is not with the parent during that visit, but now that people are at home, or you can see people while they're at home, you can have eyes on both the child and also get to see and evaluate the disruptive behavior and teach the parent skills to manage it in the moment. We might wonder if patients are understanding what is discussed over telehealth visits because we aren't in the same room with them. In order to reinforce learning or confirm the use of skills, here are some recommended strategies. I'd say ask patients to describe back to you or to teach someone else what they just learned in session. I recommend, summarizing what was discussed at the end of the call and then reviewing that session at the beginning of the next telehealth call. You can ask patients to record a part of the telehealth visit if you want them to remember, specific instructions for engaging in a technique. You can have patients watch a video. So you can send them the link and together you can watch the video. You can have patients take a photo of the notes that they took or of the form that you completed with them. So you might share your screen with that fillable PDF and you want them to have a copy of it so they can take a photo with their smartphone and keep that and save that. And that way you don't have to mail them a physical or hard copy of that form. So if they do want some hard copy of the activity sheets or monitoring sheets, you can also send them via email or in the mail so that they have those hard copies. I'd like to now present you with the vignette of an individual who presents to your clinic. As I read about this case, think about potential logistical, technological, language, and cultural considerations that you would make if you were to see this person via telehealth. Cassandra is a 47-year-old Latina who is married and currently living with her husband and 2 children. She works as a manager at a fast food chain, and recently she has suffered from frequent stomach aches and headaches, which finally led her to visit her doctor. She also shared that she has not been sleeping well for the past 3 months. Cassandra has a conflictual relationship with her husband, and they argue over parenting issues and priorities for their 2 children. Recently, Cassandra's mother, who is 75 years old, was diagnosed with liver cancer. She has a close relationship with her mother, who lives with them. Cassandra does not have an active social life, and she spends most of her time either at work or with family. So again, take a moment to read this case vignette and think about the logistical, technological, language, and cultural considerations that you should make while you are thinking about seeing this person via telehealth, or that you might need to problem solve with the patient so that you can facilitate future telehealth sessions. What do we know about Cassandra? We know that she's a caregiver, not only to her 2 children, but also to her ill mother. So she's got a lot of family responsibilities in addition to working as a manager and spending a lot of time at work. So scheduling for telehealth visits may be particularly difficult for Cassandra, and finding a private or quiet place at home may also be a challenge. We want to consider her familiarity with the use of technology. And if she's got a couple children, they might be very familiar with, remote learning. They may have, a device with video conferencing capabilities at home because the children are needing it for school. So that might increase access for Cassandra or help her with initiating those calls because she's got a couple young ones at home who can help with some of those difficulties. Consider her language and what her preferred language is. Consider, the family values, her, like I said, family responsibilities, and any other cultural values that she has. It seems like she does not have an active social life. So her social support and ability to get others to provide childcare or things like that may make it difficult for Cassandra to engage with telehealth. Before COVID-19, there were a few high-risk populations that were not typically seen via telehealth in outpatient settings. But given current circumstances, it's become a necessity to see patients with varying levels of suicidality and those under the influence of substances. Not only that, but usually telehealth would not normally be considered for children under the age, for example, under the age of 6, because it requires, to some extent, the ability to sit down and to focus on the computer screen and to listen, to the provider and to engage in the session. So that can be hard for very young children, especially those with externalizing disorders or ADHD. So with all these cases, we need to assess for level of risk. For example, suicidal ideation and self-injury. We need to think about the patient's physical safety, especially with those with externalizing disorders. We need to think about the standard of care for telehealth and making sure it's the same as the standard of care for in-person treatment. Using the same protocols, the same supervision of trainees, the same effective emergency protocols. Determining who's appropriate for telehealth should also include assessing the person's access to technology. Do they have a reliable method for contact? So if you are seeing a client who is suicidal or has very high suicidal ideation or self-injury, for example, we need to make sure that for emergency purposes, they have access to a reliable method of contact so that we can call them when we need to do safety check-ins. And if we know that they don't have regular contact or regular access to a method of contact via smartphone or a phone that isn't a smartphone or video conferencing with a laptop or computer at home, then they might not be appropriate for telehealth services. You need to also think about the potential for technical failures to occur during sessions and whether we can get in contact with those high-risk patients after the technology fails. So if we were using our laptop computers to connect for visits and the Wi-Fi from the patient's end goes down, can I call them to continue that visit or to make sure that they're safe and okay? Consider the patient's, again, expectations, level of comfort, and preferences with technology to determine whether they're appropriate for telehealth. and their history regarding cooperativeness with treatment. So I've heard both ways that, some patients who were seen in person, they would typically no-show, had a lot of barriers attending behavioral health visits in person. But once COVID-19 happened and they all transitioned to telehealth, this particular patient was now able to attend sessions regularly. So if someone might not have been a person who would regularly show for visits, telehealth might be able to increase their access to services and mean that they are more engaged in treatment. Think about their ability or your ability to ensure your patient's safety and to establish support for the patient while you're seeing them remotely. All of these things I would say we need to consider when we determine who's appropriate for telehealth. In terms of key takeaways, telehealth can address barriers that Latino communities have when accessing in-person mental health services. We know that therapy tools can be easily adapted for use online. I mentioned some of these ways, including converting handouts and worksheets to fillable PDFs, using video, using visual analog scales. All of these methods and tools can be used via telehealth. And so we can continue to use those tools and not kind of defer to not using any tools at all because it's telehealth. But this requires us to be creative and for us to know our technology. So we need to be very familiar with the platforms that we're using for behavioral health visits and the functionality, all the different tools and buttons on these platforms. We need to be familiar with them so that we can help patients also troubleshoot on their end. Cultural and linguistic factors will impact your approach to telehealth with Latino clients. We discussed several cultural values that influence the relationship or the development of a therapeutic relationship, and linguistic factors that can be a concern when trying to connect with individuals that are non-English speaking or limited English or have limited English proficiency. We also need to help patients problem solve challenges in different ways than we did when we were seeing them in person. You might feel sometimes that you are now not only a provider of behavioral health services, but also an IT person because of the logistical issues that patients can encounter when using telehealth. I also want us to consider how we can increase empowerment of patients through providing choice. What that means is that in a lot of these stressful circumstances that we're all experiencing, our patients have limited ability to choose. They don't have a lot of options. COVID-19 has left them with limited options in terms of what they can do, for supporting their family financially and helping, their children engage in remote learning at home and all the responsibilities that comes along with taking care of families or loved ones who might be ill. So options have been reduced and flexibility has been reduced for a lot of our patients' lives. If we can find ways to provide options to patients during their behavioral health visits, we can help increase their sense of control, their sense of empowerment and involvement in the therapeutic process, in their own treatment. Last but not least, share your resources. So as you develop telehealth resources and adapt materials to that modality, please share your resources with others to create a sort of repository of materials that have been created over the course of the last year. Because we know telehealth will persist even after COVID-19, we need to consider steps that need to be taken moving forward as we continue using telehealth. So how can we use telehealth services once people are transitioned back to in-person treatment? Is there a type of hybrid model that we can utilize where those who begin with in-person services might experience barriers or challenges to attending sessions, and then they can be transitioned over to telehealth? Or if we identify barriers at the beginning, initiating services with the patient, we might immediately move them over to telehealth. And if telehealth is still a barrier to them engaging in their services, we might transition them back to in-person services. Nonetheless, there might be a hybrid approach where certain visits are conducted in person, for example, the initial visit, and certain visits are conducted via telehealth. And telehealth is used more as a way to augment in-person services than a standalone treatment for some patients. We need to continue to determine which patients should continue to be seen via telehealth, so establishing some kind of assessment method or criteria for determining who is appropriate and who isn't appropriate for telehealth, and then continuing training of providers and healthcare team members in telehealth and the use of the different platforms to engage clients in their clinical encounters. Here's one website that I want to provide to you as a resource for handouts and worksheets that have already been adapted for telehealth with children and adolescents. It is a website that also has a two-part webinar series on the logistics of using telehealth and specific tips for providers. And this same team I collaborated with on a manuscript where we talked about resources and recommendations for engaging children and adolescents in telehealth during COVID-19 and beyond. So children in particular, we might need to employ different strategies for keeping them engaged on the computer with us. After COVID-19, there has been an expansion of other telemental health trainings. So I want to provide a list of those, some of which are coming from the American Psychological Association, another from the Mental Health Technology and Transfer Center. And here's the list of those trainings. Again, the public's response and these different agencies responding to the coronavirus has been to try to increase access to telehealth trainings. Again, guidelines though, and best practices can be rapidly changing as we learn more about using telehealth and as we conduct more research on the effectiveness of telehealth. Now, I want us to reflect back onto these post-test questions now that we've completed this webinar, and think about your responses to these two items. The first, research on the effectiveness of telehealth. Is it less effective, equally as effective, or more effective than in-person treatment? And number two, telehealth services may not be appropriate for patients with high suicidal risk who don't have regular access to technology, or patients with a family member who need help, to help them with technology, or patients who need an interpreter. So reflecting back on what we learned throughout this webinar, think about how you might now respond to these post-test questions. Here is a list of the references used throughout the presentation. And I'd like to thank you for your participation in this webinar.